to patients and restore the vision and helping our nation to eradicate the blindness level in our country. This day honors the contribution and dedication of the doctors in the worst of times. This day has a special significance this year. Amid the COVID-19 pandemic, doctors and physicians and especially ophthalmologists all around the world have been recognized for their selfless service and acts, working continuous shift and putting their own health in danger. This day gives a perfect opportunity to salute their work. Hats off to you guys. Today is the birthday of the famous ophthalmologist Sviatoslav Fyodorov, a renowned Soviet and Russian ophthalmologist. Fyodorov is considered to be a pioneer in several branches of eye surgery. He was the first surgeon in the Soviet Union to successfully perform implantation of an artificial lens and the first surgeon in the world to successfully use an innovative surgical technique to cure the early stage of glaucoma. However, he is most famous for developing radial keratomy, a surgical technique to change the shape of cornea and correct myopia, as well as for his overall contribution to refractive surgery. I once again welcome all my guests over here and all the speakers for giving their valuable time on this particular day. Now I request to start with the event. I welcome our respected District Governor Lion Benu Madhav Doraji and request him to share a few words with us and inaugurate this session. So good evening.
Good evening. Thank you, Dr. Vikas.
Welcome.
Thank you very much for inviting me to share something. So, Dr. Vikas, I can see and recognize Lion Sanjay Agarwal, our multiple council chairperson. As I know, Dr. S. Natarajan, other galaxy of doctors from India and abroad, all other guests present over here, and my line friends. आप सबको मेरा नमस्कार. Friend, I, on my own behalf and on behalf of our district 322C2, welcome you all to this virtual awareness seminar. Really, it is a great privilege on our part to be a part of this great seminar. Friends, you are not aware of all these things, what I am going to share right now. Our founding father, Melvin Jones, once he told, you cannot go very far unless and until you do something for somebody else. So that's what we are doing. We are doing great humanitarian service, and you are also joining hands with us, and you are encouraging us on this great day, the World Ophthalmology Day. You are organizing such type of seminar, and we are really feel proud to be a part of it. Friends, in this pandemic period, lot of challenges are there, lot of difficulties are there. In spite of all this, you have converted all challenges into opportunities and doing great services. Really, as Dr. Vikas told, I also joining him to salute you all, sir. I wish every success in your endeavor to deliver eye care service, and wherever you need our service as a line, we are ready to cooperate you, sir. I wish again all the success of this seminar, and again welcome you all from the core of my heart. Thank you very much. Over to you, Dr. Vikas.
Dr. Vikas, you are muted.
Thank you, sir. Thank you so much. Now, I request our line. I'll just introduce our multiple district chairman, Lion Sanjay Agarwal ji, who is a very dynamic leader of our multiple 322 and a very successful businessman of Jaigaon and a dashing council chairperson. He is member of Lions Club of Jaigaon Shivalik. Sir, I am very thankful to you that you have given your time for this particular event and for the valuable advices of yours. So I request you to just inaugurate the session, and then the entire eyes are set for Dr. Natarajan to start with the entire journey of this event.
Thank you, President, for calling me and inviting me in this seminar. Dignitaries and my dear line friends, on the occasion of World Ophthalmology Day, I welcome you all to this webinar on eye care organized by Rourkela Prime in association with Aditya Jyot Eye Care Hospital, Mumbai. You are all aware that one of the core activity of Lions International is vision, and Lion across the globe, including many clubs from our multiple, has been working since decades towards the cause of vision. We had been delivering extraordinary service across our eye hospital and vision center, and I hope that with the passage of time, our service will keep spreading its wing across geographies where we are yet to reach. Friends, digitization has helped in bringing prosperity across mankind and also helped in connecting people across the world with each other. Because of technology, children across the globe now have access to all latest curriculum and online courses, which are immense benefit to them. The corona pandemic has also forced the school and children to adapt to online classes, and all this has come with a cost. This had started causing a lot of strain to the vision of small children who, because of their age, are unable to feel the difference that is caused to their eyesight. Under such a circumstances, it became important for Lions to reach out to small children and go and conduct eye checkup camps at all villages, towns, and cities. Today, on the World Ophthalmology Day, I request all my club and fellow Lions to organize eye checkup camp at all school across village and town and help them screen their vision and provide them with the support thereafter. So friends, today I will not take much of the time. Today, a lot of doctors are there. We are going to hear all of them and get a views from them, and we'll learn something from our doctors. They are doing wonderful job in this corona pandemic. Hats off to all doctors. Thank you. Thank you, President, for inviting me. And a lot of thanks to Vinod Mohanty ji, my co-governor, and Vinod Dora ji, our district governor from your district.
Yeah. Thank you, sir. Thank you for your time. I welcome our IPDG Lipal chairman person, Lion Padmacharan Naikji, to this event. I'm very thankful that they have given their guidance and time for making this event. Now, not taking much of the time, I would like to introduce Dr. Natarajan, who actually doesn't need an introduction, but it gives me an immense pleasure and it's an honor to introduce Dr. Natarajan to this entire set of audience. Just a brief about him. Professor Dr. Natarajan is a Padma Shri awardee and is a renowned vitreoretinal surgeon. He has performed over 60,000 exclusive vitreous and retinal surgeries, 200 complicated VR surgeries on pellet injury patients who were injured in Kashmir, and has trained 68 vitreoretinal surgeons across the globe. He has been invited for more than 1,500 times to give guest lectures, which is highest number in the world. And he has conducted 61 instruction courses. He has more than 190 publications in journals. He has written 2 books and has done 21 live surgeries. He is also a recipient of several international awards for his exemplary work in the medical field, like Charter inductee in Retina Hall of Fame. He is one of the 2 Indian ophthalmologists to share the platform with Dr. S.S. Badrinath. And to name some more exemplary awards which he has got has Bruce Peace Prize in Philippines, a Man of the Millennium Ophthalmology Award, Distinguished Service Award, and many more. Dr. Natarajan has established an NGO as Aditya Jyot Foundation for Twinkling Little Eyes and screened 70,000 DR patients and 60,000 children. That's a big number. Through door-to-door campaign, covered over 2 lakh households and over 1 million people in slums, and has performed over 5,000 free surgeries. Apart from that, he has a Guinness World Record for performing most diabetic eye screenings in 8 hours. That is 649 eye screenings in 8 hours. He is the chairman and managing director of Aditya Jyot Eye Hospital. He is the secretary general for Global Eye Genetics Consortium. He is the board of trustee for International Council of Ophthalmology and also the chief of the advisor for Ophthalmologic Trauma Society of Africa. He is also a trustee for Shankar Netralaya. So I welcome you, Dr. Natarajan. Now the entire vision is with you, and so would love to hear your welcome address and to start this session with your introduction.
Thank you, Dr. Vikash, thanks a lot for the introduction, and thanks to the entire Lions and Lions International, particularly Lions Club of Rourkela and all the Lions governors and all the doctors, and especially Dr. A.Mahalingam and my executive Lakshmi for making this program in collaboration with Aditya Jyot Eye Hospital and Lions. And I think it's really nice, and I like to share the screen. So today we are all assembled here to celebrate the International Ophthalmology Day, and we remember late Professor Swatzlaw Fedorov, who was a great ophthalmologist. And as you see here, the entire program is organized by Dr. Dr. Vikash Agarwal, and thanks to the entire Lions for this unique opportunity. And I think the celebration is being done from 2008, and even in Russia, I think probably it was not done in such a big way, but I'm happy this year because Dr. Vikash Agarwal found out, and we have made it big. And thanks to All India Ophthalmic Society also joined Russian Ophthalmology Society, and even we kindled their interest, and then we want this to be an international event. And I was just telling in the beginning to Dr. Divya Shah that we want this event to be a thanksgiving to all the eye doctors. I know I'm an eye doctor, but still on behalf of the patients and on behalf of the beneficiaries, I think we have to thank each and every eye doctor in the world who's doing service somewhere, either through Alliance or any of the NGOs. And I think this being Alliance, and I thank each and every eye doctor on behalf of the beneficiary, that is the patients, to thank them. And I'm happy, I'm cherishing the memory of my old-time friend. He was a great friend. Even though I was young that time, I met him in '83 first, late Professor Swatzlaw Fedorov. He founded the SN Fedorov Eye Microsurgery Complex, which is a clinical and research ophthalmological center in Moscow, Russia, founded in 1988 in his memory. As a remembrance, on his 93rd birthday, Russia actually celebrates International Ophthalmology Day. I'm sure, I'm happy Dr. Vikash Agarwal found out through this link, which is given here from the Ukraine, and not even in Russia now, it's in Ukraine. And they have put it in their website, and now we have made it official as a part of Russia and India. And here you can, on August 8th, 2017, they celebrated the International Ophthalmology, and which is now, he actually was the first microsurgeon to introduce the artificial lens, as Dr. Vikash Agarwal said, along with his colleague Zakharov. So it's called the Fedorov-Zakharov Sputnik lens, because he designed the intraocular lens like the shape of a Sputnik. So I'm happy that Aditya Jyot Hospital and Lions are coming together. So, and so I think my first speaker of this program is Dr. Rashiana. So I actually want to introduce so Dr. Rashiana is an assistant professor, King Edward Memorial Hospital and Seth GS Medical College, Department of Ophthalmology, Mumbai. We're just a few kilometers away, and I found her now only. She's actually an American board certified ophthalmologist, fellow of the Duke University Eye Center, cornea, external disease and refractive surgery, and of the Miracles in Sight Eye Banking Fellowship from Winston-Salem, North Carolina, USA. awarded the Presidential J. William Fulbright Scholarship by President Obama to address preventable blindness in India. Pioneer in eye bank preparation of pre-decimus endothelial capacity graft, which is where it's one of the latest technology. And WHO team member of blindness and visual impairment for the WHO Global Blind Burden of the Disease Study, recipient of the Albert Schweitzer Fellowship, 50th Annual Eye Bank Association of America Travel Grant, and AAO Cornea Subspecialty Speaker, which is again a great honor. Very, very few people get to speak there with a few million ophthalmologists, and faculty speaker at AAO, which is one of the top-notch societies in the world: American Academy of Ophthalmology, American Society for Cataract and Refractive Surgery, Cornea Society of India, and now Pune Ophthalmic Society and World Women's Ophthalmic Society of India. And she's also organized a 2020 ophthalmological educational course series to provide education to corners of the world that don't have the opportunity to access education. And special interest: global prevention blindness, eye banking, ocular surface squamous new players here. That's for our non-eye doctors. That means eye cancer, dry eye disease, limb cell, stem cell transplantation, and residency teaching. Overall, I wanted to say Dr. Ashiana is actually she's a great ophthalmologist, and I think with a great dedication, she's a very spiritual, blessed person, and she's a disciple of the Sadhu Vaswani mission in Pune, where even Dadaji was very, very close to me, and he lives in our hearts even now. And he lived 100 years, and he has met Pope, and he just left the earth in 2 years back, but he lives in spirit all the time. And I want to publicly acknowledge that on behalf of Indian ophthalmology and to the Indian patients, thanks to her, because with all her training, and she's born in US and she lived there, even though she's having an Indian origin, but there was no need for her to come back. But she had a calling from a spiritual calling, even though I have air raising. And with that, she came to India, and it took almost 1.5 years for the government of India to give her license to practice in India. I didn't know. And when she sent a mail for a program on eye banking, I just wrote back thinking she's in US. And I didn't know she's just staying or working 2 kilometers from my home and 3 kilometers from my hospital. And she's a great dedicated ophthalmologist. And we're very, very happy that she's part of Indian ophthalmology now and representing the ophthalmology to the rest of the world. And we don't have none other than Dr. Ashiana to speak on eye banking, because we are working closely, and I have several projects lined up with her. And without wasting much time, I request Dr. Ashiana to start her talk.
Professor, thank you so much for those kind words, undeserved words, and I am just trying to walk in the footsteps of my master, very far behind. But I thank you for having me on this wonderful platform, for which I highly value, and that is public awareness. I think the key words in this topic, public awareness on eye care, is really the word awareness. Awareness of where we currently are and where are we going. And so that is where I'd like to put our focus for the next few minutes when it comes to eye banking. So let's look at corneal blindness on a global scale. 90% of the approximately 10 million people with curable corneal blindness live in developing countries. So we're talking about our India, we're talking about countries in Africa, and we still have a long way to go. When we talk about the causes of corneal blindness in India, we're focused on infection, pseudophakic bullous keratopathy, which is weakness of the cornea that develops post-cataract surgery or any sort of surgical procedure, hereditary dystrophies or corneal ectasia. This is a photograph of keratoglobus, a deformity since childhood of the cornea. Trauma is a big one, chemical injury, trachoma, and vitamin A deficiency. So when we look at a diseased cornea like that, and we're able to give a corneal transplantation for that patient to help them see, there's nothing more rewarding. So what are the different aspects of eye banking? Well, we can break it down into 5 major parts. And the first step is really eye donation. Eye donation starts with each one of us, whether we're a doctor or not. Each one of us has a responsibility to give back to society and to say that after we leave this physical body, the gift that we can give someone else is to give our organs and to give them the possibility of sight. After someone has said and consented to allowing us to receive the gift of sight from them after they pass away, then comes the work of the eye bank team to go to the hospital or to the home to harvest the tissue. That tissue is then brought to the eye bank for processing and for evaluation to check whether that tissue is suitable for transplantation or not. Thereafter, that tissue is efficiently and safely transported to the corneal transplant team, where that tissue is then given for a patient recipient. I want to highlight, and I can't highlight this enough, the importance of eye donation. This is pledgemyeyes.org, started by Professor Natarajan when he was the AIOS president just recently, started in collaboration with the Eye Bank Association of India. And when I came to find out that he is the founder of this, I cannot say enough about it. Because if we have a streamlined way for the general public, for each one of us to be able to pledge our eyes, then that is, like I said, the biggest gift that we can give another. And it hits home for me, because when I was at Duke in North Carolina, doing my corneal transplant fellowship, as well as the eye banking fellowship at Miracles in Sight, my mother passed away. And it was then that the local eye bank where my mother had passed away, the Eversight Eye Bank was the local affiliated eye bank. I received a phone call from them asking if we would donate my mother's eyes. And it was her wish that after she left the physical body, that all of her organs were given to someone in need. But with metastatic cancer, metastatic squamous cell carcinoma that she had, the only organ that could be given to anyone, just imagine, were her corneas. And months later, I received a phone call that, or rather a letter, to say that my mother's 2 eyes had been used in the city of Chicago to provide 2 people with sight. So in the midst of COVID-19, the world at large, as well as the world of eye banking and corneal surgery, are going through big questions. And we are trying to work on that. So a team of us from around the world are really trying to work in collaboration to find solutions to the questions that we have before us. And if I may take a moment to share with you sort of the insider scoop, the idea that maybe in every aspect of medicine, as well as every aspect of our life, we take a new perspective. What do I mean by that? Well, for example, when we look at COVID-19 at large, we are all focused on the countries that are most affected and finding out day to day their numbers, isn't it? But what if we take a new perspective and focus more on the countries that have 0 to very few cases and see what are they doing right? Perhaps we would develop new solutions to the problem. And similarly, may we translocate that ideal into the world of corneal transplantation and eye banking to ensure that our whole team is safe, that the donor transplant is safe for the patient who will receive it. So I'd like to break it up into 4 major solutions: innovation, collaboration, public health measures, and establishment of a roadmap based on scientific research on a local, national, and global perspective. So let me start with innovation. Here's some examples. A drone that is being used to check for temperature and coughing. That same drone is being used through the company Zipline to target blood transfusions, blood collections to major hospitals. Similarly, we also have robots that are taking up the hard work of sanitizing and doing the work that humans may not be able to. Many vehicles are being taken so that medical supplies are actually being allowed for us to receive medical supplies. So can we not use this in the world of eye banking and corneal transplantation? Absolutely. But that's going to take collaboration with scientists, technology experts such as Google and Apple, industry, and government. So let's break this down. When we look at public health measures at large, because the world of eye banking and corneal transplant is one aspect of the entire world. So we need to ensure that our team is safe, that our patients are safe through accurate detection of COVID-19. A viable COVID-19 vaccine, maintaining social distancing measures, and minimizing travel. So that involves ensuring that our eye bank technicians are kept safe and the very minimum corneal transplantation, the very necessary corneal transplantation is done at this time. Research to identify new ways in which we can preserve the corneas that we've received for a longer period of time in the midst of this crisis, and keeping abreast of new ideas. So in conclusion, the burden of corneal disease lies in developing countries. Eye donation is the foundation for corneal transplantation. The 5 main components of cornea and eye banking are eye donation, tissue harvest, eye bank processing, tissue delivery, and corneal transplantation. And finally, innovation, collaboration, public health measures, research will allow for eye banking and corneal surgery to have a roadmap so that we can then move through COVID-19 successfully. And with that, I'd like to leave with some words from Sadhu Vaswani. Where there is hatred, dear child, may you ever sow love. Where there is despair, may you send a ray of hope. Where there is darkness of ignorance, may you spread there the light of knowledge. And where there is suffering, may you, even like a star, point the path of joy and peace. And with that, I want to thank Professor Natarajan and Dr. Vikash Agrawal and members of the panel for having me today at this very important occasion.
Thank you, Dr. Ashiana, for a wonderful presentation, and I hope everybody is aware of the eye donation and the problems what we are facing earlier and now during COVID. And I think that was a very lucid presentation. Anybody from the lines have any question? So that we can have one question. Herman, you want to ask something or comment something on the eye banking? I know Lions is doing a lot of, I know right from my childhood, I grew up in Chennai, in Madras, and we have a lot of Lions Club sponsoring the eye banking, including the government eye hospital where I was trained, as well as in T Nagar, where the Lions Eye Hospital is there. So Dr. Herman and or Dr. Vikash, or Dr. Vikash, Dr. Sanjay, or Divesh, you from. So Dr.
Can I maybe say something?
Yes.
Doctor, yeah, thank you very much for the opportunity. I'll be speaking a bit later, but I think from that talk, I think it's important the need we have for corneas in South Africa as well. I think that's the biggest problem because of cultural beliefs. People don't want to donate eyes or corneas, and so we've got a big backlog on that. We've got clubs involved with cornea transplants, and yeah, that I think that is one of their biggest issues at this stage.
Absolutely, sir. So I think, you know, goes back to what I said in the beginning about awareness. And I think each one of us, if we remember that we all have a role in the world of giving people sight, then we will remember our duty. It's not just a gift we're giving, but I verily believe that it's a duty that we all have to be able to provide others with what we have.
May I? Dr. Natarajan?
Yes. Yes.
Yeah. So right now, iBanking so far is still not a priority for Sight First, but Lions are very enthusiastic about it. And we have 4 Lions Eye hospitals in Eastern India who are doing great service, especially Siliguri Greater Lions Eye Hospital. And there is a hospital in Dibrugarh also, Alipurdwar, these all remote areas. Dibrugarh is in northeast Assam, but they are doing fantastic job in iBanking as well as cornea transplantation. And there is another hospital also which is in the process of back transplantation. So eventually these people are doing fantastic job, and enthusiasm of the Lions. It's thank you.
Has to mute, I think. So, okay. So thank you, Dr. Ashana, for enlightening and opening everybody's eyes on iBanking. Am I audible?
Thank you for having me, Professor.
Yes. Am I audible?
Yes, sir.
Yes, sir.
Okay. So thank you, Dr. Ashana, for the wonderful talk on iBanking and also mentioning about the pledgemyeyes.org. As I think I'm, as a 3rd generation eye doctor, dedicated for iBanking, eye donation. And because my father always told about Lord Kannappa, who's he donated both his eyes for Lord Shiva, and which is a mythology, it's part of mythology. But he used to tell that, and he written his own book in Tamil and in English with a foreword from my mentor, Dr. Vadinar. So next is my talk. So thank you, Ashana, and I'll share my screen. So my talk is on diabetes and eye care. You all can see the screen?
Yes, sir.
Okay. So my talk is on diabetes and eye care. So diabetes is a group of metabolic disease characterized by high sugar resulting from defects in insulin secretion, insulin action, or both. So everybody knows about diabetes, and that increased sugar in diabetes is associated with long-term damage, dysfunction, and failure of various organs, as you see here, right from heart attack, stroke, peripheral neuropathy, peripheral artery disease, eye-producing diabetic retinopathy. Even long-standing diabetes can produce cataract, glaucoma, diabetic foot, diabetic nephropathy. And I see lines working everywhere. And this is the epidemic of the century. And diabetes unfortunately affects all cross-section of the people, whether rich or poor, and because of the change in diet, and that's what I see. And it's becoming a regional epidemic, and then are you or your kids at risk? And you can see these are the symptoms of diabetes. I'm sure everybody knows, and so I'm just giving a description of the 2 types of diabetes. Type 1 starts at young age, which is insulin dependent, and type 2, which is supposed to be insulin independent, which is begins in the adult life and mostly stress oriented. And that is the reason 30 plus are getting diabetes, and there's a thing called pre-diabetes. And I don't want to confuse the general public with this, but I think all of us have to be aware, like what is diabetes? It's just an increased sugar level, which normally you should have. So there is a video which... The
inner workings of the human eye are complex, but at the same time, fascinating. The eye is easy to understand if you think of it as a camera. When you take a picture, the lens in the front of the camera allows light through and focuses that light on the film. When the light hits the film, a picture is taken. eye works in much the same way. In a healthy eye, the lens is clear and allows light to pass through. Light is focused by the cornea and lens onto a thin layer of tissue called the retina. The retina works like the film in a camera. When light hits the retina, tiny cells collect the light signals and convert them into a then sent through the optic nerve and to the brain, where they are processed into the images we see.
So as you saw, the front has the cornea, which is a transparent shield. And this is what I want everybody to know in administration and in the politics, that like the eye, we should become transparent. That means the light has to pass through cornea, the front of the eye, the aqueous, the lens, the vitreous, and then the retina. So the diabetic retina, when diabetes produces, actually attacks the small blood vessels of the body, and the small blood vessels are there all over the body, and visibly changes are seen in brain, heart, eye, kidney, and by the way of neuropathy, and then when the kidney, you have the nephropathy. In the eye, it is called diabetic retinopathy, where there is a damaged blood vessel of the retina, and then it can develop either a part of the type 1 or type 2 diabetes. And it is the 5th cause of blindness globally. And that's I always believe in documentation, and that's part of the reference you have. And prevalence of diabetic retinopathy in India is about 16.9%, and there is a variation between 16 to 20. But the main thing is diabetes, I think, is a really an epidemic which is happening. And diabetes is not a epidemic waiting to happen. Actually, it's happening. And unfortunately, every diabetes is affected by something. So if they don't have complication, they have prevented it. So okay, you have to congratulate every diabetic who does not have a problem. Instead of he telling that I am okay, I think he should tell how he is okay. And unfortunately, diabetes is not a curable disease. That means, what do I mean by that? It's not like you take diabetes one-day treatment and you're all right. No, you have to. It's a lifelong disease. It's a lifestyle disease. So you have to manage yourself daily. So I remember my father, when he was alive, used to tell the patient, like diabetes is like an animal. Don't catch the animal by the tail. You have to catch head on. That means what? You control, you train it's like a dog you take. You train, you pet him and make him under your command. Same thing is diabetes. And the eye symptoms are too late. And not only that, you don't get a symptom at all and you may go blind. So prevention is better than cure. So the risk factors, smoking, obesity, eating the diet as you see here, all which is, and then inactive life, sedentary life, and then if you're, it's here 40 and above, but it's again 30 and above. And in case your father, mother have diabetes or sibling have diabetes, you have to be extra careful, because diabetes can come through diet, through genetics, and through environment also. That's why it's called epigenetics. So, and it can be associated with blood pressure also, which is a wrong and a deadly combination. So when the diabetes affects the eye, we have several stages. You can have a normal eye where the circle which you see with the yellow color is called where you see the dot and blot hemorrhages, and sometimes you have flame-shaped hemorrhages, which can be a part of blood pressure. Without any of this, with only the blood vessel, you'll see that's a normal eye. Here, this is called mild non-proliferative diabetic retinopathy, and in this stage, the patient will be totally normal. And sometimes patient does not know they have diabetes. What does that mean? That means they already have diabetes, and to get this stage, minimum it takes 5 years. So in India, I don't know about the rest of the world, but at least in India, I can say that we don't do a routine fasting sugar and a postprandial sugar and HbA1c every year. For example, according to me, if you are prone, you should start from 30 years of age. If you are no family history, you are normal and everything, then at least you should start at 40 years instead of looking for a symptom. And then a second stage will be moderate non-proliferative diabetic retinopathy. You can see some yellowish patches, that's called the exudates, the hemorrhages. Still the vision can be normal. And then you have, again, you can see multiple red dots all around in the back of the eye. The eye, that's why I showed the video, where eye is compared to a camera, and where the film is, that's where the retina is, and that's where which is important because if you don't have a film in the camera, you can't take photo. Same thing here. If the film is damaged, you cannot see. And that's what happens here. But the centermost is called the macula. Many times it is not affected. That does not mean retina is healthy. So even in this stage, the vision can be normal. And then you have the second stage, not second stage, the final stage, where it's a proliferative diabetic retinopathy. You can see like angry looking blood vessel, which is marked as proliferative diabetic retinopathy. And you can see the white arrow showing, and another white arrow showing abnormal vessel. That means normal blood vessel is there. And because of diabetes and blood vessel is affected, you develop new blood vessels, which can bleed and produce blindness. And that's what a layman should know. And every diabetic do not go blind. And that's another good thing whether God or nature has done. And then if you don't treat at that stage, and still at this stage when the bleeding happens, you will see something like a black cloud coming and blocking the vision. And if the center of the retina is not covered, still you can have good vision. And that does not mean you are healthy. So what do you call the eye, when you see from external, you can't make out. And when the patient doesn't have complaint, doesn't mean he does not have retinopathy. And that's what I want to convey. And you see here on the picture, there are two pictures here. In one picture, you see a center part clear, and there's some yellowish, like straight line like things going. And still, if the center is not involved, your vision can be normal. But anytime, overnight, this patient can lose the vision. And then this stage, when you operate, the chances are also very bad because you can see fibrous tissue pulling the retina, and then bleeding is starting. And when you touch, it is like touching the fire. That means you are putting the hand in the fire. Either you, as a surgeon, you get burnt, or as a patient, you lose it is like the whole fire devastating the whole building or the property. And then, so that is why when a patient goes to an eye doctor, and if he is a regular eye doctor, he will check the retina and tell you have this advanced retinopathy, and then you may have to go to the retina doctor and do the test. One is a photograph, and that's called the fundus photography. They do a color photograph, they do a retina, the red-free photograph, and then we have a test called fluorescent angiography, where we give injection in the hand and take photograph of the retina. And the other is if they have a hemorrhage, you can't see the retina, then we do sonography. They're like a ultrasonography or a B scan. And then we also do a test called optical coherence tomography called OCT. You can see a picture which shows like a mountain where it's like a swelling of the retina. And these things can produce loss of vision. So the treatment available is laser photocoagulation. And when we do a laser, we actually maintain the vision. So if you come with less vision, you can't get improvement with laser. So that's the biggest problem as an eye doctor or a retina doctor we have. Because as a layman, the patient wants with any treatment improvement. And in the eye, and particularly in diabetes affecting the eye, it is a problem. So we have to have, patient has to learn self-health education by going through internet, by reading, and then asking the general doctor, asking the diabetes doctor, and we have and then surgery. So here you see in the picture, one eye where I have white small spots, that is the laser photocoagulation. Center part is kept empty, that's called the macula, and the other one like a small, like a moon-like picture, and that is the optic nerve, and which conveys the signal from the retina to the brain. And vision is a part of brain, as you saw in the video. So the idea of the laser is to destroy willfully the peripheral retina so that the oxygen requirement of the central retina is less, thereby the center of retina is maintained. So even though the laser has side effects like side vision can be affected, color vision can be affected, but 99% patients don't realize it, and they can lead a normal life. And the right eye is a different type of laser, left eye is a post. After some time, the laser has been done. So even after laser, you can see some streak of blood happening. That is why the frequent checkups are required. And many times, people tell me, patients come and, sir, I've done 10 times laser or 5 times laser. I think that, and after that, they develop a complication. They tell, oh, because of the laser, I lost the eye. But they don't understand the laser is done to prevent the problem. It is like already the eye is in the fire. What is the fire? Diabetic retinopathy. And that time, you're trying to put the fire off by laser, and in spite of the laser, if the retinopathy fire is not put off, how can you blame the doctor? But the problem is nobody wants to educate themselves. So the whole idea of the International Ophthalmology Day is to encourage you to understand the science and the pathology, how it happens, so that you can prevent your own self. And these are the injections which can be given. And this is the operation which myself have been trained by Dr. Badrinath. And Dr. Badrinath brought this technology from Boston to India, and already Dr. Nambarmal Sabna also was trained there in Boston by the same mentor from Arvind, Dr. Nakpal from Germany, and many others who brought this technology.
She used this as the basis to build up a beautiful research network in her hospital. She managed to train so many MPhils in contact lens research who are now across the country. And everything was a building block for the next step. As a clinician, she was outstanding. Any problem you had, anything that you needed done, anything that you would like to see introduced in the hospital, all you had to do was tell her, and she would go out of her way to do it. I remember all the times that we had in the lead sugar.
Yes. Hello. I think due to net issues, Dr. Natarajan has got disconnected. I think he'll be joining us soon. Yeah, he's back.
Sorry, the internet had some issues, I think. I'll come back. Now, can you hear me? I think I have a few more slides. Go. Yes. So prevention is better than cure. So that's what I want to take home message. And so the main thing is we have introduced, as a president of All India Ophthalmic Society, I have introduced the effective screening program for diabetic retinopathy, which is already there, started by Shankar Netralaya, Arvind Eye Hospital, many hospitals in India. And the main thing is we are now trying to find a methodology where instead of the patient going to the doctor, we have trained non-medical people who can screen for diabetes and send the patient. And if you are a diabetic, if you are type 1, type 2, you make sure that it's under control. And then main thing is to control the blood pressure and make sure that you don't have any of the risk factors. And this is one of the patients who came blind. We have made a YouTube video called Aditya's Happy Smile. I'm not going to play the video because of the time this thing. The idea is we are training non-medical people who we are using the mobile phone and using artificial intelligence. We can send to all villages of India, and we are trying to make a skill development corporation. And then we can screen only people who need eye treatment should go to the eye doctor, and that's what we have published in JAMA. And then so that we can the eye doctor can treat the patient in time and prevent blindness. And thanks to my grandfather and father who are ophthalmologists, so together they have done 150 years of service. And I want to, Swami Vivekananda is my inspiration. So I want this as a goal where diabetic retinopathy, we should produce diabetic blindness free India. So for that, I want to sensitize every Lions and every public to arise, awake, and stop not till the goal is reached. What is the goal? You cannot remove diabetes, but you can control the diabetes and you can prevent diabetic blindness. Thank you very much. And with this, I will again introduce the next speaker. And in the meantime, by the time I introduce the next speaker, can I have, if you have any question, maybe we have time for one question. Can I, anybody who wants to ask a question or a comment? Dr. Agarwal or Sanjay? Anybody wants to ask question?
If anybody wants to ask the question,
Yes,
just raise your hand on the reaction.
The line is not clear.
Yeah. Thank you, Dr. Natarajan, for giving us a broad vision about how this diabetic retinopathy is hammering everyone's life and how it is taking a future. And I just would love to know that I was very much excited by this particular your presentation when I came to know that you have made such arrangements that now in that patients does not to visit doctors, but rather you are training people who can visit these people, these patients, and can help them out. Apart from that, you are taking this particular diabetic retinal screenings, DR screenings, which we say across in each district. So from my Lions Club end, I'll be very happy if we can get associated and we can help this out and assist you in making this in every district, at least in Odisha and nearby areas.
Sure. Yeah, definitely, sir. I think it's a great. I'm happy we could initiate this, and we have to do that. We need everybody to work with us, and
Yeah.
thank you for that, and thank you for
My,
that support. Now,
my pleasure, sir.
I'll introduce Dr. Vinit Ratra.
Yes.
Dr. Vinit specializes in one second. He specializes in cataract and glaucoma specialty. His expertise in managing various types of difficult cataracts. After his graduation, he trained in the world famous Shankaracharya, a renowned tertiary eye care institute, which is my mother institute, and postgraduate training center, where he was mentored by Dr. Badinath. He was elected a fellow of the Royal College of Surgeons, Edinburgh, UK. He has been a senior consultant in the Department of Cataract and Glaucoma at Shankaracharya for 21 years. He has close to 20 publications and awarded D.V. Chandra Award for the best scientific paper in glaucoma in the 68th AOS conference, and he has also had the best poster at the American Academy of Ophthalmology 2011 and received runner-up prize for the best video in the American Society of Cataract Surgeons. So, Dr. Vinit, I'm stop sharing my screen. You can start your talk on cataract. Vinit?
So, good evening. Can I start? Can you hear me?
Yes, sir.
Hello, can you hear me? I'm not able to hear.
Yes, yes, yes.
Hello?
Yes, Vinit. Yeah, we can hear you. Vinit?
Check. Okay, I think I'm having some internet issues.
Oh.
Sir, we can hear you.
Yeah. We can actually see your screen. You're able to hear us? Vinit?
Hello?
Yes, Vinit. We can
Yeah,
hear you.
so can I start?
Yeah.
So at the outset,
Yes,
let me thank Dr. Natarajan and the Lions Club of Rourkela for having me over. Sorry. So the World Health Organization estimates that nearly 18 million people are bilaterally blind from cataract in the world. They represent almost half of all the global cases of blindness, and cataract remains the leading cause of blindness and an important cause of visual impairment across the globe. Well, what about India? The National Blindness and Visual Impairment Survey, which was conducted from 2015 to 2019, showed that nearly 63% of all blindness in India was because of cataract. They also found that nearly 71% of moderate visual impairment in people greater than 50 years was due to cataract. cataract is the most significant cause of treatable blindness. Globally, it accounts for nearly 57.1 million people with moderate to severe impairment. These are 2020 statistics, and 13.4 million who would be blind due to cataract. Around 20 lakh new cases of cataract are added to the burden every year. Recent data, this is from the National Program for Control of Blindness, shows that in India, an average of about 56,000 cataract surgeries are performed every month. So this brings us to a few questions. Let's start with what is cataract? What are the symptoms of cataract? So a cataract is a clouding of the natural intraocular crystalline lens that focuses the light entering the eye onto the retina. This is how Dr. Natarajan had shown that video about how the light focuses. When the lens gets opaque, like it's done here, less amount of light enters onto the retina, less or no. This is similar to the lens of a camera getting scratched, but this is a progressive condition and one gets a gradual deterioration in vision over time. The symptoms may vary depending on the type of and severity of cataract and could vary from just a little brownish nuclear cataract, which can be seen in a nuclear cataract, to slight haziness in certain types of cataract early, to a nearly complete loss of vision. One could also get double or ghost images. One could be extra sensitive to light. They may find vision in bright light or in sunshine to be difficult due to glare. And at night or low light conditions, the vision may be dramatically reduced. One may also get halos around light, as can be seen here. This brings us to our next question as to what causes cataract. Well, aging is the most common cause of cataract. It occurs because of a breakdown of the proteins in the normal lens of each individual. The lens starts getting cloudy. But do remember that it is not possible to predict how quickly a cataract progresses or develops. However, uncontrolled diabetes or elevated blood sugars, use of medicines like steroids, ultraviolet exposure, that is going out in the sun without protective eyeglasses, smoking hastens the development of cataract. Certain conditions like an eye injury, certain ocular diseases, patients who have had previous surgery like a vitreoretinal surgery or a glaucoma surgery, or certain patients who have a family history, that is a genetic predisposition, their brothers, sisters, uncle, aunts have glaucoma, are at a higher risk for cataract development. So what does a cataract look like? So this is what a total mature cataract would look like. This is a hypermature cataract. And then depending on which position the cataract is, it can be classified as nuclear when it's the central part, posterior subcapsular, as you can see here, in the back portion, and anterior when it is in the front portion. So this brings us to our next question. How is cataract managed? And if you have cataract, what can you do? Well, for one, quit smoking. Smoking has been known, and this is one of the research which came out from Shankar Nethralaya, to hasten the progression of cataract. Systemic control of diabetes, see that your blood sugars, as Dr. Natarajan sir said, you need to keep a good tight control of your diabetes. You need to protect your eyes from UV light. That is, whenever you go out, use UV protective glasses. Go and get your eyes checked and see if a new pair of glasses are going to help you. Try using brighter lights, magnifying lenses to see if you're able to manage your reading. If you have a night glare and find difficulty in in driving at night, avoid driving. And if all this does not work, then you need to go to your eye doctor to get a complete eye examination done. So when do you actually need to remove a cataract? One needs to plan to remove a cataract when it starts affecting your confidence and ability to be a comfortable normal, which is again dependent on an individual. A young 40-year-old who has some amount of cataract and has to feed his children at home and is an electronic engineer would not be able to do his normal work. He wouldn't be able to drive to work, come back from work, would need to plan for earlier cataract surgery than someone who's sitting at home just watching TV and reading books. Do remember, however, that impaired eyesight increases your chance of injury. So what is a complete eye examination that you need to undergo? You need to get a checkup, you need to get your vision, you see if a new pair of glasses help you, get a intraocular pressure check. Dr. Ganesh will tell you more about glaucoma. Get your retina pupils dilated so that the retina can be examined. And then the eye specialist would examine you, check your eyes, both on the slit lamp and see the retina to determine what is the cause of the problem. Are further investigations required and will help decide what is best for you. So if you have a normal retina like this, then yes, you should end up getting good vision. But like Dr. Natarajan said, if you have a retina which is affected because of diabetes or age-related macular degeneration or glaucoma, cataract surgery will not restore the vision which is lost from these conditions. This brings us to the next part. What are the intraocular lenses? Well, there are different types of intraocular lenses. The oldest and the time-tested ones are the PMMA, where you need incisions of at least 6 to 7 millimeters to insert these lenses in. Then come the foldable monofocal. These are made up generally of either acrylic or silicone. In acrylic, you have the acrylic hydrophobic. This is the material which is most inert and is one which most preferred material. Then you have the multifocal, where you have rings like etchets on these lenses. So your dependency on glasses will reduce. But obviously this comes at a cost of reducing amount of light entering and a little amount of glare. And a toric, say if you have a high astigmatism, then to neutralize that astigmatism, one could place a toric lens following a cataract surgery. Once that is done, the patient goes to the counselor, where we call it a surgery fixing center. They get educated, their surgery is scheduled, they undergo. Then comes the next part of what tests do they need to do? How is the cataract removed? Well, the first thing that they do is to undergo an IOL power calculation, because you want to place an intraocular lens in every patient. You get a pre-anesthetic checkup where the required blood tests are done and ECG is done. Other tests are determined by the anesthetist, after which the patient is shifted to the operation theater. Here, this is our anesthetist, Dr. Kannan, and one of our postgraduate students who is watching how a local anesthesian block is given. Some of these surgeries can also be done with just topical anesthetic eye drops. Cataract surgery or work in the operation theater is always a teamwork. This is in our community ophthalmology center. This is Dr. Smitha, and this is Gangotri sister, who keeps everything ready while the surgeon scrubs and comes in. This is our autoclave. This is where the sterilization process takes place, and this is the team which is generally there in one OT. You will have 2 OT assistant boys. This is a postgraduate who's learning, and this is the scrub nurse who will be there. So there are various safety measures that are taken, which all of us would take, so that we do not get, there are no infections which develop. Among them is checking sterility of instruments, both the sterility outside and inside, where you have specific indicators which tell you that yes, the autoclave has gone on well. Every patient's, every instrument box which is sterilized would have these indicators. Once this is done, then one would plan to go in for surgery. So the surgery which is probably most commonly performed would be the phacoemulsification, where you use ultrasound energy. Here you're making making an opening in the front portion, that is the anterior part of the capsule. The incision in these would vary from around 2.2 millimeters to around 2.8 millimeters. Then using an ultrasound energy, using these phacoemulsification machines, you can emulsify, that is, make it into smaller pieces and absorb the cataract away. Once the cataract is removed, you just need to clean up whatever cortex is there and then place an intraocular lens in the eye. So in this case, since it was a 2.75, you would want to place a foldable intraocular lens. So the next most common surgery would be the small incision cataract surgery. The small incision cataract surgery, this is the surgery by one of our very talented postgraduates, Dr. Jayashree. So where you make an incision of around, this incision is around 7, they have back cuts. But this incision inside would be around 10 millimeters, 8 to 10 millimeters. These are self-sealing wounds, and at most times would not require sutures. So over here, the cataract is, again, the front portion of the capsule is removed. The lens is then delivered out, and after that, an intraocular lens is placed inside the eye. So this is a very neat surgery by her. The third surgery, which is most commonly done, is the conventional extracapsular, where you need to cut open the eye, where you need sutures. Here the incision size would vary to around 10 millimeters, depending on the type, on what the surgeon would assess would be the size of the cataract. So here again, you make an opening in the anterior, the front portion of the lens capsule. You open the eye, you deliver the cataract, and then put an intraocular lens. So you can see here, this is a total cataract, but it's a very hard, black nuclear cataract. Then you would deliver and you would put the lens in and then suture the eye. So, but there are certain, though cataract is a very safe procedure, there are certain risks in cataract surgery. The first would be the inability to place a lens while you're operating. This occurs when the capsule, which you remove the front portion, the back portion of the capsule support is generally good, but in certain cases it may not be good enough to place an intraocular lens. Sometimes, though these lenses which you place could move away from their position, and these could either fall into the vitreous cavity and need to be taken out from there. The other risk could be that of a vision loss, which could occur because of an eye infection, which is very, very rare, which is less than around 0.3%. In the world over, in our institute, is also very low. It is 1/10 of that. You could have a bleeding in the eye. You could have a swelling in the front of the eye or inside of the eye, a swelling in the central retina, a retinal detachment, or a thickening of the posterior capsule, which is the second most common cause of poor vision in these patients beyond 50 years of age. So what is your recovery from cataract surgery? You would need to use eye drops. You would avoid water in the operated eye. There should be no rubbing, no pressing. You don't want an injury, so you would use protective eye shields and eyeglasses. And you would need to review with your surgeon on day 1 and day 3 or 5. And finally, on the final checkup, that could vary from 2 to 6 weeks, depending on the type of surgery. This is one of the innovations at Shankar Nethralaya, which we are very proud of. This is the MISU. This is the mobile eye surgical unit, which consists of 2 buses, which join together at a local campsite. They get joined together like this. This was in collaboration with the IIT Madras that this was formed. It becomes a complete state-of-art surgical theatre center with a generator, with air conditioners, with an RO water plant, with everything. We have performed nearly 78 camps and more than 10,000 surgeries on this MISU bus. Well, like Dr. Natarajan said, myth is if I see fine, my eyes are all right. Well, no, you need to consult an ophthalmologist regularly, at least once a year or as advised. And remember, the care and protection of this gift of sight is our responsibility. Well, thank you. This is a team of my community of boys. These are the same boys who were there when I started my learned my cataract surgery. That is nearly 20 odd years back. That is Arshu, Shiva, Murga, Ramanan, and this is Dr. Smita, who's now our academic in charge. Thank you.
Thank you, Vineet. I think cataract you covered very well, and Lions is doing a lot of activities on cataract. And I think now Dr. Vikash wants to introduce our Lion Herman Smith. So, Dr. Vikash. Dr. Vikash. Thank you, Vineet.
Thank you, Vineet sir, and thank you the speakers, those who have actually enlightened us with a lot of information. Now I would like to introduce our multiple council chairman from district 410D, that's in South Africa, Lion Herman Smith. Lion Herman Smith is into Lionism for more than 23 years, and he's a council chairman for this multiple district 410. He has various other positions on cabinet for district 410D. He's happily married to Lion Lady Bardine, and he's also an executive chairperson of CAP. He's a non-profit company focusing on job creation, education, and support to people with disabilities in South Africa. Sir, I welcome you to this particular event, and thank you also for this for giving your valuable time for conducting us this session. And it's an honor that, and very important, on this particular day, 2 different countries are joining hands and having this particular session. Thank you, sir, and welcome. Good evening.
Good evening, and thank you very much. It's a great honor for me to be here tonight, and thank you for the invite. It's a special day for eyes, and it's a special day for me as well to be here. And I must say, listening to all the speakers before and all the interesting stuff they talk about, it's just incredible. And I think the importance of eyesight must be emphasized. I don't think we always realize how important the work is that is being done. And on this special day, I would like to thank all the doctors that work so selflessly with people. I think in South Africa especially, our ophthalmologists, sorry for that, they give their time for free for our Lions clubs to help patients that need cataract operations and transplants. So we've got a few clubs that is really involved in cataract operations and eye care. One is actually in District 410W, and I see the district governor, Peter, is here from that district. Welcome, Peter. And yeah, the Neisner Club does a lot of cataract operations. They've special days where they do around about 15 to 20 operations in one day, where they help patients with cataracts. But our biggest problem, as I said previously, is when it gets to eye care and cornea transplants, is the scarcity of corneas. And most of them gets imported because South Africa can't supply them ourselves. So what the eye care in South Africa is one of our focus areas as well from the Lions clubs, from our multiple districts. So we've got a lot of clubs involved directly with cataract operations and cataract and eye care. But we also have a multiple district operation called Operation Brightside, where we support clubs to do eyeglasses at very special and affordable prices so that we can help the people in need in our communities. But I don't want to focus on that. One of the things that I want to focus on this afternoon quickly is that, and it comes back to our children, that we did a bit of research on our children, grades 1 to 3. You know, in South Africa, we have a school dropout rate of about 45 to 50% of children that do not get to grade 12. Most of them fall out between grade 7 and 10. They fall out of school. And we found that the biggest reason for this is that children can't read when they get to, well, they can't read. The child passes grade 3 and he gets to grade 4 and he's not equipped to read. He almost never catches up. So we've got a lot of children falling out of schools because of not being able to read. And in conjunction with the Western Cape Education Department, we went into schools and we did vision screening of all the grade 1 to 3s of about 1,500 children. Because what happened, we went into schools and you go into grade 1, grade 2, grade 3, and you don't see a lot of children with glasses in those classes. And we said, but this is just impossible that children do not have sight problems. So we went in and we screened all these children just to see what's happening. And we found that between 12 and 15% of those children had eye problems. They couldn't see properly, or there was some other problem with their eyesight, and they needed additional care. And I think why I'm saying this is that we don't always realize the impact of helping people with eyesight is having in your communities. You can imagine 15 to 20% of our children can't see properly, and at the end of the day, they can't read. What happens to them when they get to the higher grades? They just fall out of school. And those are the kids that never get employed. Those are the unemployed people in our streets that struggles for the rest of their lives. And I think one of the things that we are pushing now is that as Lions, we get involved in screening of all children in schools in grade 1 to 3 to make sure that they get help and support, and that we do not have a problem with them not being able to see, and that's the reason why they can't read. I think as Lions, we've got a big organization. We need to take hands, and I think with our doctors and with the caregivers to make sure that we support our children in this way. One of the things, the way it works in South Africa at some of the clubs, especially the Neisner Club, what they do, they've got an agreement with a local government hospital that supplies the facilities. The Lions Club supplies the consumables that's used in these operations. And then the optometrists, they come in and they give their time for free. That's why I think these doctors is just a special breed of people willing to come in and spend time and helping patients without asking any money for it. And we want to thank each and every one of you that's here today and worldwide that really goes out of their way to make an impact in people's lives. And I don't think they always get the thank you they need to get. And from our side in South Africa, we want to thank you for what you do for our communities and for the long-term impact you are making in people's lives. In the future, it would be great for me if we could work together, if we can take hands across borders, across countries, to really address this problem that we have in our communities. And lastly, I'd like to say diabetes in our country is a very, very, very big problem as well. And I don't think, I just now realize more and more the impact that can have on sight as well. And we have more and more young people having diabetes. We need to, as Lions, we need to really focus to do awareness and take hands with the people that know and make an impact in this area as well. I thank you for the opportunity to be here. And I want to congratulate the club on this initiative. It's something special. And yeah, it was a great honor for me to be part of this. Thank you very much.
Thank you, Herman. So next, thank you very much. And I think we will all work together because diabetes that's my dream, using artificial intelligence and using non-medical people, using mobile phone to screen diabetic retinopathy. My dream is for India, Africa, and South America. So that's my dream. So we'll work on together. And I think one man can't do it. We have to have a lot of people to support us. So I want to introduce the next speaker.
Sir, 1 minute. I just like to inform Lion Herman. First, I'll thank him for his great words. And I'll also like to inform him that Lion Herman, Dr. Natarajan is a Chief Advisor for Ophthalmic Trauma Society of Africa.
Hello?
Hello, am I audible?
Yes,
sir,
yes,
sir,
yes.
Yeah, the Lion Herman, I just want to inform you that definitely Dr. Natarajan can be of help to you, and both can get associated because he's also the Chief Advisor for Ophthalmic Trauma Society of Africa also.
Oh, that'll be fantastic if we can talk in the future and see how we can take hands to really make a long-term impact in our communities as well.
Sure. Dr. Avika Agarwal can connect us by email and I can share my number, so no problem.
Sure,
Thank you,
sure.
Herman. Thank you, Herman. So next I have the pleasure of introducing Dr. Ganesh Venkatraman, and he joined Aravind as a consultant in 2005 and continues to offer his services there till date, where he is the chief consultant of the glaucoma services in Aravind Hospital, Coimbatore, India. He is heading the department with 6 consultants and 4 fellows, and the facility is well equipped with 2 Humphrey Field Analyzer, and everybody knows Aravind is well equipped. He has 25 publications. He has authored chapters in radiretinal in ophthalmology, manual small incision cataract surgery, and practical perimetry. He received the Young Ophthalmologist Travel Grant awarded during the World Glaucoma Congress, Vancouver, and he's a former Glaucoma India Education Program Coordinator and for the Glaucoma Society of India, and conducted 10 CME program. Presently, he's the secretary of the Coimbatore Society of Ophthalmology Surgeons. And here, Ganesh, I'm stopping my screen.
Thank you, sir. At the outset, I thank Professor Natarajan, Aditya Jyot Eye Hospital, and Lions Club of Rourkela Prime for having me to speak to you on glaucoma. I'll just share my screen. Can you see my slides, please?
Yes, yes.
Thank you, sir. Thank you very much, sir. So I'll be speaking to you a few minutes on glaucoma. So glaucoma is, I studied in Jabalpur and Indore. So everywhere there, it is also known as Kala Motia. So if you know Kala Motia, you would know glaucoma. So it's a disease of the optic nerve at the point where it leaves the eye to transmit the visual information to the brain. So you saw Dr. Natarajan speak to you on how the retina gets affected, and then the signals don't get transmitted to the brain. So it affects the optic nerve. So you saw cataract, you saw the disease. And if you leave it, most types of glaucoma progress, and they cause without warning and symptom to the patient to vision damage and may lead to blindness. So it is known as a silent killer of vision, a silent thief of sight. So you saw Dr. Vineet Ratra and Dr. Natarajan say that the leading cause of blindness is cataract, then it is followed by glaucoma, diabetic retinopathy, and age-related macular degeneration. The most important aspect to remember here is cataract is reversible. If you lose vision because of cataract, you can regain. But if you have associated glaucoma, or you have glaucoma alone, or diabetic retinopathy, or age-related, the vision cannot be reversed. So that is one important aspect which we have to take into consideration. So preventing all these diseases is more important than So how many people have glaucoma? So population-based studies mention that 2.5 to 3% of individuals over the age of 40 have glaucoma. 90% of the individuals with glaucoma don't know they have glaucoma. So that is another important aspect we have to understand. It is a silent thief of sight. 90% don't know they have glaucoma. 50% of the patients, when they are diagnosed, already have severe vision impairment. What is that severe vision impairment? I'm going to show you. So what is the mechanism? So there is what we have to understand is there is a fluid circulation in the eye. So the fluid which comes out as tears is different from the fluid which is inside the eye. Inside the eye, it is known as aqueous humor. So the aqueous humor is not able to drain outside the eye. There is either a age-related functional problem, or it is a mechanical blockage, because of which the pressure in the eye increases. This damages the structure which is known as the optic nerve, which you can see here, which sends signals to your brain, messages to the brain to understand vision. And this leads to damage, and this can cause glaucoma, and that means loss of peripheral field of vision. This animation is Just a second. So we know that if you see this video, the eye is connected to the brain by means of a structure here called the optic nerve. The optic nerve sends signals to the brain so that we understand vision. We appreciate vision. The front of the eye has the cornea, the iris, and the lens, and there is a fluid circulation. That is the aqueous humor. It goes through the structure called the trabecular meshwork, which is in the front of the eye. That's known as angle of the anterior chamber. If the structure is damaged because of age, the fluid is not able to go out. It gets accumulated in the eye. All other structures can tolerate this pressure, eye pressure, but unfortunately, the optic nerve cannot tolerate this eye pressure. It starts getting deteriorated. It starts getting damaged. In the initial stages, it doesn't affect vision. In the later stages, as the optic nerve starts getting damaged, you can see that it starts changing its shape. It becomes more and more yellow and starts bending backwards. So that causes a peripheral field of vision. For this photograph, if you see, slowly the darkness starts coming from the sides. The patient is not able to appreciate that. And finally, it leads to a very advanced stage. So this is open angle. That means the angle of the antechamber was open. Now, if you see another situation in which it's a closed angle glaucoma. Again, as I mentioned, there is a optic nerve which transmits signal from the eye to the brain, something like the spinal cord, which transmits signal from the hand and leg to the brain, something like that. And here, the aqueous humor, the fluid circulation is happening. But in this situation, in angle closure, because the iris, this is the iris tissue, which is closely opposed to the cornea, the angle of the antechamber gets closed. This is known as angle closure glaucoma. And because this can happen because of diabetes, because the lens gets swollen, and there are many other causes for this. If you have a thick lens, this can happen. And because of this, you can see that the points, the fluid is not able to access the trabecular meshwork, and the pressure in the eye increases, again damages the optic nerve, and again it starts. So both these conditions can happen very slowly over a period of many years. So the important aspect is that we have to identify it very early. So the hallmark of glaucoma is field loss. This picture here shows you a normal vision. Patient is seeing a full image of this photograph. In early glaucoma, this side peripheral vision reduces. And in intermediate, you can have moderate glaucoma, in which it is in between the early glaucoma and advanced glaucoma. In advanced glaucoma, you don't see anything in the side of the picture, the margin of the picture. You just see the center. In end stage glaucoma, this is what happens. You just see the boys, but you don't see the trees around or where they are running, whether it's a road or a park. The patients tend to miss this. So what happens when the patient starts developing advanced glaucoma? In early stage, it doesn't do anything. Patient leads a normal life. But early to moderate, it can start affecting the driving because he cannot see anything on the side. And moderate glaucoma, patient can have more number of falls. And in advanced glaucoma, reading can become difficulty because they tend to read the same line again and again. Especially if you read small font, for example, a Bible, you end the line and then you start again, you're reading the same line. So you get frustrated. In advanced condition, because the side vision, the peripheral vision is not there, patients feel very disoriented. They don't know where they are, whether they're in a temple or in a market or in your clinic, or they're gone to some other doctor's clinic. So disorientation can always occur in advanced field loss. So what are the types of glaucoma? So you have classification by age, and you have congenital glaucoma, juvenile glaucoma, adult onset glaucoma. In this situation, I'd like to point out Mr. Herman Smith's point that many people, when he tested in South Africa, they were not able to read. The children not able to read. One of the important causes also glaucoma which has not been detected. And according to the cause, whether it's a primary or secondary. So primary is you cannot identify the reason. Secondary is trauma, drugs, other ocular disease, or intraocular surgeries. They themselves can cause glaucoma. On the site of obstruction. So if you have in the drainage system, you have open angle like I showed you in the video, or you have closed angle, which I again showed you in the video. So congenital infantile glaucoma occurs in children. Both eyes are involved in 75% of patients, and it is very common in children born of consanguineous marriage. That is, marriage within the same family members or within relations. And in birth, there is a defect in the drainage channel. Risk factors. The most important risk factor is family history. If somebody has glaucoma in the family, if your parents have glaucoma in the family, then there is a almost 10% chance that the next generation may have glaucoma. It can also skip a generation, as shown in the photograph here. If your sibling has glaucoma, there's a 5% chance that the other sibling can also get glaucoma. Age is another important risk factor. More than 40 years, definitely people should get checked up. High refractive errors. If they are using high minus power or high plus power, they should get themselves for glaucoma, because high minus power can cause open angle glaucoma, high plus power can cause angle closure glaucoma. Smoking. All of us have been talking. Dr. Natarajan has spoken about smoking. Dr. Vineet Ratha has spoken about smoking. I'll also emphasize that smokers will have high chance of glaucoma. A recent study has come from the American Society group, in which smokers have a high intraocular pressure than compared to non-smokers. Eye injury, any form of injury. Most important is steroid. In India, you can go to any pharmacy and ask for any medication. They'll give you any medication. So steroid drops, steroid creams, mometasone, or aspirin, the inhalers, for example, the steroid inhalers, they can cause, in predisposed individual, they can cause glaucoma. And systemic conditions like hypertension, diabetes, heart problems. So you have to remember, not only for corona, even for glaucoma, these are all very important conditions which can aggravate glaucoma. How do you do checkup for glaucoma? So first is tonometer, that is measuring the eye pressure. Second is gonioscopy, to see the angle of the anterior chamber or the drainage angle of the eye. Third is examining the optic nerve. Fourth is visual field examination. These are four functions which Dr. Vineet Ratha also mentioned. We'll show you some of the photographs. So this is my colleague who is examining the patient. He's doing the eye examination. And then this is my colleague, she's doing photometry test. So we touch the eye after applying anesthetic agents. It's a painless procedure. And then there's a gonioscopy to check the angle of the anterior chamber. This is again a painless procedure. And then the optic nerve examination or the optic disc examination. And this is the visual field testing machine. So what we do is a visual field test. This is an automated perimeter. You can see our staff is administrating a test here. And this is the printout which we get. So the doctor can interpret. If you look here closely, it is 95 because there are certain black spots. This patient has early glaucoma. That is in his left eye. This right eye, if you see, it is 100%. He doesn't come in that eye. So like this, we can identify what sort of field defect the patient has. The idea of treatment is to maintain him at this field level status, not allow him to go to a worse condition like this. If he happens to worse, for example, this patient has a 52% loss. And in the left eye, in the right eye, he has got 67% loss. So we can quantify how much loss each individual patient has. And this plays a very important role in day-to-day activity. For example, if you look at this image, this individual who is driving the car is able to see the pedestrian here on the pedestrian pathway. Whereas if he does glaucoma, the image disappears. He's not able to see the car and the individual crossing the street. So what the brain does is it will fill in the wall and the traffic light. So it gives you a false sense of security that there's nothing there, but actually it's a very serious situation. So glaucoma tests are very painless procedures. So I want to emphasize here that all the tests are painless procedure. They are sight saving. And how often should one get his or her eyes tested? So if you have got yourself tested and the doctor still says that you don't have glaucoma, nevertheless, because its age is a risk factor and other comorbid conditions like other diseases which can affect you later on in life, you must undergo an eye checkup every 2 to 3 years. Glaucoma patients, if they have glaucoma, they will be usually given a follow-up visit. So 4 to 12 months is the intervening time. Early glaucoma, you can see the doctor once in 6 months or once in 12 months. Moderate glaucoma, you can see once in 4 to 6 months. Advanced glaucoma, 3 times a year. It is very important. At least once a year, you must do all the investigations. That is the field test. If it is a stable glaucoma and the doctor is certified that you are stable, then you should follow the doctor's advice and come as per the visit. What are the treatment options? So you have medications. Mainly it is eye drops because orally taken medication don't enter the eye because eye is part of the brain. It is something called blood-brain barrier, which blocks the medication. That's why you take a lot of medication, but you don't have side effect of the brain. The second is laser. So you have 3 laser procedures which are commonly done, and then surgery. So surgery is to drain the fluid from the eye. We have numerous medication. I won't go into the details of it. It is recommended that you follow the doctor's advice. He will be the best person to judge what medication can be given for an individual patient based on the patient's risk factors and his health profile. But the important thing is how to apply drops. So first of all, now we have in Corona era, you have to wash your hands. So that's a given. Number 2, tilt your head backwards while sitting, standing, or lying down. Pull your lower lid down to make a small pocket, which you can see here, and squeeze the bottle gently. If possible, squeeze it from the rear. Don't squeeze it from the side. From the rear, the one drop will exit. Another drop which comes can retract into the eye as you leave the pressure. Let the drop fall into the pocket and gently close the eyes for 5 to 10 minutes. I usually recommend 10 minutes for closing the eyes. So laser procedures are for increasing the outflow. As I mentioned, angle closure glaucoma, you have a mechanical blockage. And in open angle glaucoma, you have a dysfunctional, non-functional trabecular meshwork. To release that, you have 2 laser procedures. You can also reduce the aqueous humor inflow into the eye, which is known as cyclophotocoagulation. We won't go into too much details of the procedures. I just suffice to say that this is a small photograph which shows the iridotomy. You make a small opening in the iris tissue here, and this angle of the anterior chamber opens up. Laser iridoplasty is again something similar. What you do is you use a lens, and then this is the angle of the anterior chamber, which is the trabecular meshwork. This trabecular meshwork allows the fluid to go. In older people, it doesn't function properly. So you use a laser beam to sort of ablate the you use a laser beam to activate the tissue so that it starts functioning again. And the aqueous humor starts percolating through the normal trabecular meshwork, which was actually dysfunctional before. After that is the surgery. Surgery of the for glaucoma is the most commonly performed surgery. It's known as trabeculectomy. And what the surgeon does is he makes a fine cut in the transparent tissue of the eye, which is known as conjunctiva. Beneath the conjunctiva, you have the white part of the eye. All this is done beneath the upper eyelid. He makes a trapdoor. The trapdoor, through the trapdoor, he enters a small opening is made into the angle of the antechamber. The brown part of the eye, that is the iris, is also removed. And the trapdoor is closed with fine sutures. They don't irritate at all. And the conjunctiva is closed over that area. So the aqueous humor, that is the fluid within the eye, has a pathway to go inside, outside the eye, and starts accumulating in the subconjunctival space, that is the beneath the conjunctiva, and slowly absorbs. As it absorbs, it reduces the eye pressure. That is the principle of the surgery. Now, if the tissue here is not sufficient for surgery, then there are another procedure which we can do little back at the, you can say little about 8 to 10 millimeters away from the brown part of the eye. So here we use something called a glaucoma drainage implant. This is a big implant. This is almost 350 square millimeters device, and we keep it beneath the muscles of the eye. And there's a tube which takes, which goes into the anterior chamber, which is in the front. We suture the implant here so that it doesn't move. It should not move. All these devices are biocompatible, so they don't cause any irritation. They don't cause any trauma. You don't have to remove them. You don't have to exchange them. The intraocular lenses, which Dr. Vineet Ratra showed, are also the same way. Once you have tied the plate and the tube to the white part of the eye, you test whether it is functioning or not, and then you insert the tube into the angle just in front of the angle of the anterior chamber. And it remains so and continues to drain fluid outside the eye under the tissue. So cosmetically, it doesn't cause any problem. And once you leave it there, we can make small openings. These procedures are done for, and then you use a patch graft, that is a donor sclera, that is a donated eye bank donated sclera and then cover that area because it can cause erosion. So once it's done, you can see that the tissue covers the whole implant totally. And once the tube starts functioning, this tissue here, it will start absorbing the aqueous humor slowly, gradually over a period of many days. So this is just to show you in brief how glaucoma procedures work. As the fluid gets filled up, it will slowly absorb, and the tissue, all the structures will absorb the fluid. So the end result will be a low intraocular pressure, that is reducing the eye pressure. So in summary, I'll like to say that glaucoma is a lifelong disease. Early detection can limit disability. Family history, one of the significant risk factors. So I would request anybody in the group or any of your known to are having glaucoma, I would request that they encourage their loved ones to have an eye examination to rule out glaucoma and follow your doctor's advice. If you're not being following up, I would suggest that you take an appointment immediately and start following up again. For more information, you can always look up our website, www.arvind.org/disease.glaucoma by Arvind Eye Care System. And also we have very good website, World Glaucoma Association. The website is glaucomapatient.org. You have a lot of information on that. I once again thank Lions Club of Rourkela Prime and Dr. Natarajan sir for giving me this opportunity. Thank you.
Thank you, sir.
Ganesh, I think very, as you mentioned, it's a slow vision killer, and I think you really elaborated well. And I think I'll now request Dr. Vikash Agarwal. He wants to introduce my very old friend, and I think Vikash, Divyesh is a long-time friend, but anyway, you wanted to introduce, so I'm allowing you to introduce. But I only want to say he's a great human being.
Thank you, Natarajan, Dr. Natarajan.
Thank you, Dr. Natarajan. He's really a great person, and it's an honor to introduce Dr. Divyesh Shah. He's a pioneer of LASIK and phaco surgery in Eastern India, and is involved in teaching of phaco, LASIK, and contact lenses to ophthalmologists and optometrists. Dr. Divyesh Shah is a technical advisor of Sight First for Lions Club International Foundation for 70 Lions Eye hospitals in Eastern India. He has received Shresth Samman, a felicitation from Rotary International for professional excellence in the field of eye care. He has also been awarded from Indian Association of Community Ophthalmology for social service from Governor of West Bengal. He has national and state ophthalmology conferences. He is involved in training ophthalmologists and optometrists in phaco emulsification, LASIK, and contact lens fitting. Currently, he is the treasurer for Bengal Ophthalmic Society Trust. And thank you, sir, for being here. And I welcome you on behalf of Lions Club International and Aditya Jyoti here. Now over to you.
Thank you, Dr. Lion Vikash Agarwal, for the kind introduction, and thank you, Dr. Natarajan, for saying nice words. Yes, we go a long way back, no question about it. And Chairperson, Council Chairperson Lion Sanjay ji, our guest Council Chairperson from South Africa, Lion Smith, Dr. Natarajan, present district governors, past district governors, Lion leaders, and dear friends. Thank you very much for giving me this opportunity to talk about a fantastic program of Lions Club International Foundation called Sight First. It has been a great program, and it has really changed the blindness scenario all over the world since last more than 30 years. So I'll speak a bit about the Sight First program, what are its objectives, give you an idea of what it has done internationally, and then speak about what we are doing in Eastern India under this program. So we have an idea about what all can be done under this program and how we can help people. The mission of this program is to develop and strengthen comprehensive eye care systems. The word comprehensive is very important in the underserved community, enabling them to fight blindness and vision loss and assist those who are blind or visually impaired. It also supports high quality, cost effective, sustainable and equitable eye care projects. Focus is on infrastructure development, human resources training, eye care service delivery, and high health education. More than 319 million US dollars have been approved for various projects all over the world. 1,209 projects are going on under this program in 102 countries. More than 9.3 million cataract surgeries have been performed worldwide under this program. 1,351 eye care centers and training institutes have been built or supported by this program. 2.3 million health workers have been trained all over the world. 188 million doses of Zithromax have been distributed to control trachoma. This is mostly done in Africa. And also 310.3 million doses of Mectizan have been distributed for river blindness, also in Africa, in association with Carter Foundation. The last two, all these programs have been majorly successful, especially the cataract programs, the trachoma program in Africa, and the river blindness program, also in Africa and South America. Another very noteworthy achievement of Sight First program is association with Arvind Eye Care Institution to build up a fantastic program institution called LICO. And LICO has played a major role in training not only the Lions hospitals all over the world, but also other hospitals who are interested in doing community work. Sight First has also given major grants to major institutions like LV Prasad, Shankar Netralaya, and other medical colleges also in India to do various research work as well as in various projects. In India, if we compare with the rest of the world, India has been given a large chunk of the grant. Now it's more than 325 grants. More than 26% of all Sight First grants awarded all over the world. And if you can see, it has got the major chunk of all the grants provided all over the world under this program. And the pie is definitely so far more in favor of India, and it is all because of the fantastic job that the Lions in India are doing with so much enthusiasm to help in the control of preventable blindness. There are 325 Sight First grants in India. 2,21,49,401 cataract surgeries have been provided. Huge numbers of children have been screened for uncorrected refractive error through Sight for Kids program. More than 150,000 children have been treated or given spectacles. (1,474) individuals have been trained, 4 research grants have been awarded, and 3 active Sight for Kids in association with Johnson & Johnson are still on in India. And if we see the zone-wise distribution of the grants, East and South have got the major grants. And the number of project-wise, East India has the maximum projects in India. These are the grants, main headings under which several grants have been provided in India. In Eastern India now, if we come to Eastern India, now there are almost 71 Site First projects. 69 are actively working right now. A major number of projects are in West Bengal. And if we see the grants approval summary, there are so many headings under which the grants have been approved, like Vision Center, Teleophthalmology, Manpower Management, Hospital Upgradation Grant, Cataract Grants, which has now been suspended, Diabetic Retinopathy Grant. I'll talk about these projects in short, so that you have an idea what all goes on in Eastern India under the Site First program. One major program which we undertook in 2007, 2008 and 2009 was the Diabetic Retinopathy program, in which several of our hospitals in our multiple were involved under the guidance of Regional Institute of Ophthalmology. More than 3 lakh people were screened for diabetic retinopathy. Thousands were treated, and training was also provided to the human resources, the doctors, as well as the paramedical staff at Regional Institute of Ophthalmology. We had the first teleophthalmology project under Site First program in the whole world. This teleophthalmology project was approved in 2008-2009, and it helped in reaching remote areas in North Bengal. North Bengal happens to have a large percentage of blind people because of the poverty, because of the distance, remoteness of the region. Very few people can reach those areas, and also the poverty. So these areas were largely helped by the teleophthalmology project. Again, this was only the second program in the whole world which we got in Eastern India, retinopathy of prematurity. And under this program, along with the Priyamvada Birla Arvind Eye Hospital in Calcutta, we screened the prematurely born children. Prematurely born children have a chance of getting blind because of certain ailments, growth of unnecessary vessels, and which can cause permanent blindness in these newly born children. And these need to be seen and diagnosed very early in second and third week of the delivery only. And they have to be treated, otherwise they get blind. And this was a very majorly successful program, in which also we treated, not only screened and treated, we also did awareness programs in the pediatricians as well as gynecologists and ophthalmologists. We also trained ophthalmologists and paramedical staff in this program. This was another major program called Pediatric Cataract Initiative, which was taken by the Site First. And only 2 programs were done all over the world. One was in China and one was in West Bengal, Siliguri Greater Lions Eye Hospital. In this program also, we created a huge level of awareness among the people. We went door to door from people's houses to houses to screen children, to diagnose, and also to operate for cataract in children's eyes. And this was how we went about doing this program. The program has also been a very majorly successful program under the Site First. We are doing this program in association with Johnson & Johnson Vision Care, and we are doing it in all these places where school-going children from the age of 5 to 16 are screened. Their eyes are screened, and if required, glasses are given free of cost, and even the treatment is given free of cost at our Lions Eye hospitals. So overall, so far, we have screened more than 17 lakh children and provided treatment and glasses to so many kids. This has been extremely well appreciated all over the world and in general population. Even the government of West Bengal has appreciated this program. This was another landmark program which we did in North Bengal, again, as I said, because of the huge level of blindness prevailing in that region. And this region has a lot of areas which are very remote. People are very poor, and to access these areas is also very, very difficult. So we had 3 hospitals participating in this program, and a lot of vision center. We created a lot of vision centers, and so that people could be approached, people could go to the villages, people could reach the unreached, and screen them, diagnose them, and bring them back to the base hospitals for treatment and cataract surgeries. The outreach camps and vision centers in our multiple, that is Eastern India, has been also very successful. We have been emphasizing on having vision centers and huge number of outreach camps since 2005-2006, and as a result, most of our hospitals, all 69 or 70 of our hospitals have large number of vision centers, and in the remote areas, so that they can approach the people and people don't have to travel, and these have been very successful. Now, 2 of our major hospitals out of 70. One of them is Siliguri Greater, one of the best in our country. They are doing around almost 14 to 15,000 cataract surgeries in a year, and they are comprehensive eye health providers. They have almost all the departments available, and they are also developing a training institute. They are also training ophthalmologists apart from the paramedical staff and optometrists. This hospital in Patna has been doing close to 20,000 cataract surgeries in a year. And the main basis of their work is, again, outreach and vision centers in the remote areas of Bihar. We also have developed a Sight First Hospital manual, which can help all the persons who are interested in doing work in the blindness prevention programs. This manual is to help the Lions also who are interested in establishing any level of hospital, starting from vision center to the tertiary care hospital. And it gives a good idea about how to go about it. So now in Sight First 2 program, the main emphasis is on development of comprehensive eye care systems. Comprehensive means not just doing cataract surgeries, we also have to screen people for glaucoma, diabetic retinopathy, which, as Dr. Natarajan and my previous speakers have emphasized, they are becoming very important reasons for blindness, which are very much avoidable if detected early and treated. Target underserved population, deliver high quality eye care services. The quality is to provide, not just provide free eye care, but also provide high quality eye care services is very important. Create sustainable eye care services. Measure results and use data collected to identify and evaluate the effort, and provide high-tech equipment. These are the future challenges which we are facing. Cataract is very much there. As the population is increasing, more and more people are getting old and they need cataract surgeries, and we have to keep providing cataract surgeries. But now we are also giving more and more emphasis on diabetic retinopathy and other causes of preventable blindness. Thank you very much for your attention, and thank you very much again, Dr. Vikash Agarwal, for giving me this opportunity.
Thank you, Divyesh, for a wonderful Lions is doing wonderful work, as you pointed out about Lyco and Arvind, and so I'm glad. So I think we will have to work together to combat that 77 million diabetes in India, with 58% do not know that they have diabetes. So now I'll introduce the next speaker, that is Dr. Padmaja. So Dr. Padmaja is currently the head teleophthalmology for LV Prasad Network and vitreoretinal surgeon. And being a vitreoretinal surgeon, my colleague, we are working on several projects together. She is currently adjunct associate professor of ophthalmology at the University of Rochester, New York. She completed her basic medical degree from Rangaraya Medical College and her MS from Osmania Medical College, Hyderabad. She did a postdoctoral fellowship in VR at Shankaranatralaya. So she's again and followed by a fellowship with ICO and basic and clinical science assessment. She completed FRCS Glasgow in March 2016. She is an expert in the management of diabetic retinopathy with 16 years of professional experience after completing the National Board Certification Fellowship in vitreoretinal diseases. I'm glad to say I work with her in our area. She's also part of our diabetic retinopathy task force of All India Ophthalmic Society, and I'm glad she accepted to. My screen was not shared.
Yes, sir. Yeah, not shared.
Okay, you are already shared. Sorry. Okay. Thank you, Dr. Padmaja, for joining us. And
Sir,
great
thank you,
to
sir.
have you.
Thank you, sir, for the kind introduction. At the outset, I would like to thank Dr. Rajan and ever enthusiastic and inspiring individual for all of us. And we look for him for inspiration. And Aditya Jyoti team and Dr. Dr. Vikas Agarwal and Lions Club has been my first project of my career in Shankaranatralaya. We have done a big project under leadership of Dr. Tarun Sharma, the Lions Club International Foundation. So it has been always a dream come true for me in terms of diabetic retinopathy projects with Lions Club International Foundation. So thank you all. So today the topic is teleophthalmology in COVID era. So I'll just discuss about telehealth concept and what are the guidelines, especially when you are a patient and attendant, what actually the teleconsultation guidelines and what in LV Prasad we are trying to do in the teleophthalmology portal. And also some of the indications that can be, managed by teleconsultation alone. And we also did some work on visual acuity apps that can be used by the patient to record the vision and put in the teleconsultation portal. And also, most important is the image, the smart phone anti-segment, how patients can take pictures by doing a selfie imaging of their pictures so that the doctors can diagnose condition as well as the devices. So if you look at telehealth, so telehealth as per the World Health Organization, it is actually healing from a distance. So what we can consider as a telehealth is, for example, if you are talking to, if you are able to talk to the doctor by video call in the form of virtual check-in. Now, right now, how we are having a virtual educational activity. Similarly, sometimes you might send reports through email to the doctor, or or you could be even transferred through their WhatsApp message or through an attendant getting the reports and then for transferring to you and answering the patient phone calls. And then second opinion. Sometimes, for example, if one particular doctor is having some opinion, he can actually consult another doctor about that. And similarly, healthcare workers and remote rural areas are an optometrist in our ophthalmology fraternity or a vision technician at the vision center. They can also consult the doctor. All these concepts are actually called a teleconsultation. When we say teleconsultation, because of the corona time, because of the social distancing measure and lockdown effect, there was a huge gap that was there. And that was actually realized by the Digital India initiative, and the government of India actually promptly acted on this and then brought out these telemedicine practice guidelines. So according to this, we need to consider teleconsultation as an in-person consultation, and the consent is very, very crucial. The patient should be giving consent, and if the attendant is actually trying to take the consult, then the patient consult also should be obtained through attendant. Then teleconsultation fees also can be as per in-person visit, and the documentation also has to be very clearly mentioned, and also along with the registration number of the doctor and as well as the mobile details, everything, contact details, and the documentation and the call logs also have to be kept. And few of the restrictions, like for example, previously someone seeking consultation through the WhatsApp or phone calls, those restrictions have been kept in the legal. But now, because of this corona activity and all, these HIPAA instructions, that is Health Insurance Portability and Accountability Act restrictions have been removed. However, public facing platforms are not allowed for teleconsultation like Facebook Live or TikTok, because they will let others to view and exchange. legality, we need to keep the teleconsult logs and records. It's a very a fundamental for teleconsultation is a good teleconsultation portal is to have an integrated electronic health record, because that forms a basis for your electronic medical, forms a basis for building a good teleconsultation platform. And record keeping, we need to keep all these records at least for 3 years, and in a medical legal cases need to be kept for at least for 7 years. Then there are also some mandatory certification is required for all the doctors who are practicing telemedicine, and this is actually an initiative by Telemedicine of Society of India. Through this link, they are actually trying to give the certification after providing the the course content. One need to pass, and one who want to practice telemedicine should also have this certification. Now let us look at what is that. When we say healing from distance, that means practically you are meeting the doctor without any personal in-person visit. You are trying to meet through either a video call or by WhatsApp or by through phone or by email. So when you are trying to have a teleconsultation portal, it's important that you need to make sure that the main mode of mechanism will be through your smartphone. So it's important to follow some instructions so that your teleconsultation process is very effective. Please make sure that whatever registered mobile number that you are entering is actually correct. And also your booking teleconsult and your relative name, verify that the phone number is updated so that the doctor can actually talk to your relative. And understand the consent statement before booking the teleconsult, and upload your previous reports and tests. And also if you have any of your photos of your eye condition which can be taken by smartphone, if you upload, these all will make this consultation process very effective. Similarly, for vision testing, I'll share in the next few slides how vision also can be tested by simple apps like Peak Visual Acuity for distance, Smart Optometry, which can be tested for the near vision. So you can actually even upload your vision measurement and write down all your complaints on a piece of paper, because timing is important for you as well as for your doctor. Then one should understand that a new consultation, for example, we have never seen you through teleconsultation. It's very important that it has to be done with the help of video call or report availability only. During teleconsultation process, make sure you are available at the current appointment time and your network is working well, and approximate time available will be around 15 minutes. So if you have uploaded all your reports, case history and all, about time can be utilized very effectively. And after teleconsultation, check the prescription and report that you have received. If any doubts, definitely consult the doctor immediately through the email. And one need to understand that the teleconsultation is not a replacement for in-person consultation. So you need to follow the doctor advice when they asked you to come for follow-up. So this whole teleconsultation, teleophthalmology has become a very important topic, especially after we had a corona time. So what happened on March second week, or by March 21st, everything nation went into lockdown. So in LV Prasad Institute, we used to have a footfall of almost 1,500 patients per day, and which has become 50. So then definitely all the patients, everyone started getting anxious, and then we have set up, initially we set up through our electronic record base, we set up a kind of a teleconsult system immediately, and this actually made 3 things possible for our patients. One is called triage. Triage is like when the patient calls, and we could see whether the patient actually requires an in-person consult immediately, emergency, based on their complaints and based on any available reports. And most of them are our follow-up patients. So we know what is their history. So we could actually see, and also we could even give them a certificate saying that you need an in-person, you had a sudden loss of vision, you need an in-person prescription, could actually act as for them to get an emergency police permission and could actually travel to our site for the surgery or the treatment. Similarly, the second common most facility that we could provide for our patients was management of medication, because most of the patients who might have undergone surgery or who might have undergoing like chronic conditions like glaucoma, so what is the management that need to be done, or someone who's on steroids for any this thing. So we could actually manage their medication through teleconsultation itself, advise the prescription that this could be tapered, and we could actually this. And third, and definitely not the least, the most important thing that we could provide is reassurance. For example, a patient was just suddenly developed little redness and they could share the photographs of their eye, and we said that this can happen after surgery, don't worry. So, and we could even connect to our local alumni who are there, that you can show there and then send us the report. So this reassurance was also another important thing that we could do. Definitely, we need we realize that the teleophthalmology is going to be there forever. So we simultaneously we built a portal. Our portal is called LVPA Connect Care, which is a teleconsultation app. So here, typically, the patients either through SMS or through the internet, they can register their name through this Connect Care application at the ask.lvpa.org. So what there is a facility, there is a chat bot, an artificial intelligence mediated chatbot will be there, who will assist you to actually upload your reports if anything is there, or your photographs, everything. And then one can go for the payment pathway if you are a paying patient. But if he is a follow-up patient, and if he is a non-paying because in our hospital we have equity, both non-paying and paying. So if the non-paying patient need not pay, so then the doctor's schedule can be picked up, and the doctor will be able to do the consultation, and through video as well as through the chat box as well as through the WhatsApp. So the doctor will actually simultaneously enter the details in the Connect Care app through the electronic record, and the record and the prescription as well as both will be transmitted to the patient through the email as well as the through phone through the SMS. So we are also looking at other options like home care, because this COVID crisis is going to be further and deepen. So those patients like geriatric patients who cannot reach us, or those elderly patients who cannot reach us, we are also trying to go through the models of home care. So that is in the pipeline. So the teleophthalmology, the model that I talked was after Corona. Even before Corona, we had a teleophthalmology because we had a unique pyramidal structure where we had a primary eye care, secondary care, and tertiary care, and center of excellence. So we have around 200 centers across the 3 states, and we actually defined primary consultation, what are the conditions that can be managed by the teleconsultation alone. And similarly for secondary eye care also, we have defined what are the conditions that can be managed by teleconsultation alone. Like for example, 1 week post-operative patients, then anti-surface, only anti-segment conditions like conjunctivitis or surface lesions. So we have defined for each one what are the things that can be managed by teleconsultation. Similarly, in the specialty wise at the periphery, in the tertiary center also, we have defined some of the conditions which can be managed by teleconsultation alone. So, and what we have stressed at the primary eye care center is actually all the images, the vision centers which are there in 186 locations, we on a daily average, whatever the conditions that requires teleconsultation will be sent through images to the through our electronic record. We have an iSmart electronic application record. So through that, actually the images are transferred to command center, that is the teleophthalmology command center at the LV Prasad, Hyderabad, and the images are seen by the doctor and ophthalmologist, and the necessary advice will be given. And so we have even defined image protocol, because image protocol is very, very important to get an appropriate teleconsultation advice. And we stress on very good quality images, and we have some slit lamp adapter so that the vision technician can take good images. And because a good image means appropriate management, and that can result in excellent patient care. So these are all the few images that are taken by our vision technicians from the vision centers, and one can see very clearly, and the teleophthalmology doctor can give proper advice, and various conditions, whether it could be lid infection or a conjunctival, the front part of the infection, even if there are some changes in the uvea inflammation, these all changes could be actually picked up, captured very well by the photographs, and one can see. And we need to understand that sometimes a suspected cancer lesions, something like this lesion is a suspicious of eye cancer, can also be picked up by one simple photograph. And what is important is to stress on the protocol of the image, and this can be done not just by the vision technician, but can be captured by the patient themselves also. So these are all conditions that can be managed, and we try to see because one important measurement as an ophthalmologist we feel that we want whenever we want to consult a patient is what is their vision. So we did one test, one study during this Corona time itself with all the social distancing protocol. We tested 2 apps which can be freely downloadable on the internet. One is called Peak Visual Acuity, which is for distance vision. The patient need to be checked at around 2 meters distance, and which is a simple tumbling E protocol where the patient will be able to tell. And this now the phase 1 we have tested with our employees whether they could download the app, whether they could understand the instructions, and we tested their check. And most important is we validated these visual acuity apps with our in-person testing, that is the Complock system, and we found that the peak visual acuity was very good for the distance vision, and smart optometry was reasonably good for the near vision. So what we would recommend is for distance vision, a patient can easily, attendant can be trained, and there are nice videos available in the web, and now we are testing with the patient also. That is the second phase of study is going on. So where Peak Visual app can be downloaded free on your Android phone, and distance vision can be measured, and this can be uploaded for the teleconsultation portal. Similarly, smart optometry for near vision testing. And this is another device which we have in our innovation team, which can be called folding phoropter, which actually patient himself can check whether the target which he is seeing clear or not, and can give you an approximate value where your eye power also is there. So this is also another device which we are trying to now these are all devices which are available at our primary care center, but now we are seeing how patient friendly it can become, so that patients can use that and can also use in our teleconsultation portal. Then this is another simple instructions to the patient, how they can take their own eye image. And by following these instructions, patients can actually take beautiful images. These are all captured by the patient attendants, and they could send us these images. And one can easily give the advice, basic advice, what that need to be done, how serious it is, and what is the next step that can be done. Easily, it was solving as the purpose of triage, whether the patient needs immediate in-person consult based on their complaint, etc. So these are all simple techniques which we can follow, so that our teleconsultation process becomes effective and useful for the patient. And this is the device now we have developed in the LVP Center for Innovation, which is a small clip-on for any camera. It is any smartphone, it can be used. And this is the main advantage with this device is there is no slit lamp required. Image of clinical grade can happen from the home. Patient relatives, it is easy to learn within 1 minute. They are used to smartphones, and doctors also it will be useful when they are away from the clinic, as a portable slit lamps are very expensive and can have use in dentistry and dermatology as well. And we realized that both rural and urban patients are technically savvy, because during this lockdown, we found that even our rural patients could capture very good photographs, and we could do nearly 600 teleconsults of our rural network as well. So this is how the images that has been captured with our anti-segment device. These are all pictures that are taken by the patient themselves, the patient attendant themselves. So it works as a very magnifying lens, and you can get a clinical. These are all the patient images that are taken from the patient eyes with the disease pathology. You can see that the quality is very good, and this is a very cost-effective device. Maybe we are expecting that it will be the more the mass the production, the device cost will come down, but we are expecting within under 1,000 rupees. So that is what we are expecting. And this is something even one can even do for fluorescent as when the doctor uses the tool, one can even do the fluorescent staining. So this is a very handy tool which can be just clip on for your camera, and you can actually do this service, so that all the anti-segment conditions can be easily picked up and can be managed. So and this is another innovation that we have in LV Prasad. We call drone slit lamp. We are trying to see how we can now popularize right now, keeping this in our isolation room where COVID positive patients are anything. The advantage with this is that the slit lamp eyepieces are replaced by the cameras, and the doctor at a distance in another room can actually sit and can actually, it's a robotic slit lamp. so can actually examine the eyes. So this has been actually pioneered. We did work with University of Miami, and Dr. Parel and Dr. Mukesh Taneja was a pioneer in activating this work. So now we are trying to see how we can actually popularize this innovation as well. So there are many tools that are available, mainly with one important underlying statement, that is so comprehensive eye care, holistic eye care. Recently the World Report on Vision said that we need to have something called people-centered eye care. So our idea of LVPI teleophthalmology model is a technology integrated people-centered eye care solution, so that we can have global social and scientific impact, so that all may see with excellence, equity and efficiency. Thank you for the opportunity.
Thank you, Dr. Padmaja, for a very elaborate and beautifully explained teleophthalmology. I think I learned a lot. I'm sure the audience in the Facebook, YouTube, and all the non-medical people have learned, and including medical people. So I think teleophthalmology is definitely a great boon at this time of COVID. As you said, from 1,500 patients to 50 is, I mean, shocking to many things, right? From treatment to revenue. So I think, thank you, Padmaja, for a wonderful talk. So I will now introduce the next speaker, that is Dr. Kaushik Murali from Bangalore. So Dr. Vikash, I think we should share every speaker's email to whoever is participant, so that they can write to them, because there'll be a lot of questions. Dr. Kaushik Murali is a pediatric ophthalmologist and strabismologist. He has special interest in public health pertaining to child eye diseases, and also has research interests in the areas of binocular vision and artificial intelligence in eye care. He also serves as the president, medical administration at Shankara Eye Foundation. And with Bangalore, he completed his DNB at Shankara Eye Hospital, Coimbatore, and thereon did his pediatric ophthalmology fellowship at the Medical Research Foundation, Chennai. He is also an alumnus of INSEAD and completed a course on strategic management of non-profits at the Harvard Business School. He has been recognized at the AOS with 2 awards for his research projects. Over the years, he also collaborated with institutions like Harvard School of Public Health, University of Bonn, and the London School of Hygiene and Tropical Health on various public health research projects. He is currently member Scientific Committee of Vision 2020 India, and also the regional chair South for Confederation of Indian Industry Young Indians. And Kaushik was part of the Indian delegation at the G20 Young Entrepreneurs Alliance in 2018 in Argentina. And he's going to talk to us on preventive ophthalmology. Dr. Kaushik.
Thank you so much, sir. It's indeed an honor to be a part of this august audience where we are celebrating ophthalmologists. I take this opportunity to recognize my fellow ophthalmologists who've been frontline health workers, as well as have been serving throughout this pandemic. And a big thank you to the Lions Club of Rourkela for hosting this event. So I'll quickly take you through preventive eye care. Why is this important? Well, we are talking about preventing a problem to a 576 megapixel camera, which is what our eye would be if you were looking at a technical specification. And this is a very intricate organ. We have about 107 million light sensitive cells in our eye, which helps us to identify about 500 shades of gray. So that's how intricate our eye is. And the eye is one of the fastest acting muscles. So it's almost about 16,000 times that we blink our eyes in a day. So this is why it becomes very, very critical. You heard all the speakers through the evening share with you how a normal looking eye like this, due to diabetes, hypertension, or various other eye conditions, the retina can become like this if we are not able to prevent it. This is a picture which is very dear to me. This is a photograph of a child, Nagaraj. He's a 13-year-old student who we identified through our Rainbow Preventive Eye Care program. This is a tiered, structured screening program that we at Shankara have been running continuously from 1986, where we use teacher volunteers as primary screeners. This child has this big smile on his face because he's been just given a -8 diopter glass that has helped him from being recognized as the dullest student